Pulmonary tuberculosis, PTB. Introduction. Tuberculosis is an infectious disease that primarily affects the lung parenchyma. It also may be transmitted to other parts of the body, including the meninges, kidneys, bones, and lymph nodes. The primary infectious agent, M. tuberculosis, is an acid-fast aerobic rod that grows slowly and is sensitive to heat and ultraviolet light. Tubercles, tiny lumps, are a characteristic finding in TB. Most infections show no symptoms, in which case it is known as latent tuberculosis. About 10% of latent infections progress to active disease which, if left untreated, kills about half of those affected. The classic symptoms of active TB are a chronic cough with blood-containing mucus, fever, night sweats, and weight loss. Definition. Pulmonary tuberculosis is an acute or chronic infection caused by Mycobacterium tuberculosis. Tuberculosis is characterized by pulmonary infiltrates, formation of granulomas with caseation, fibrosis, and cavitation. Tuberculosis is an infectious disease. Tuberculosis, or TB for short, is an infectious airborne disease caused by various strains of mycobacteria, typically Mycobacterium tuberculosis. It is commonly spread from one person to another through fine respiratory droplets. Pulmonary tuberculosis, TB, is a contagious bacterial infection that involves the lungs. It may spread to other organs. Statistics and incidences. Tuberculosis is a worldwide public health problem that is closely associated with poverty, malnutrition, overcrowding, substandard housing, and inadequate health care. M. tuberculosis infects an estimated one-third of the world's population and remains the leading cause of death from infectious disease in the world. According to the WHO, an estimated 1.6 million deaths resulted from TB in 2005. In the United States, almost 15,000 cases of TB are reported annually to the CDC. After exposure to M. tuberculosis, roughly 5% of infected people develop active TB within a year. Types of tuberculosis. I. Pulmonary TB. Pulmonary TB is active TB that involves the lungs. It's likely what most people think of when they hear tuberculosis. Patient contracts it by breathing in air exhaled by someone who has TB. The germs can remain in the air for several hours. Along with the general symptoms of TB, a person with pulmonary TB may also experience persistent cough lasting 3 weeks or longer, coughing up blood, coughing up phlegm, chest pain, shortness of breath. Types of PTB. Active TB disease. Active TB is an illness in which the TB bacteria are rapidly multiplying and invading different organs of the body. The typical symptoms of active TB variably include cough, phlegm, chest pain, weakness, weight loss, fever, chills, and sweating at night. A person with active pulmonary TB disease may spread TB to others by airborne transmission of infectious particles coughed into the air. Latent TB infection. Many of those who are infected with TB do not develop overt disease. They have no symptoms and their chest X-ray may be normal. The only manifestation of this encounter may be reaction to the tuberculin skin test, TST, or interferon gamma release assay, IGRA. However, there is an ongoing risk that the latent infection may escalate to active disease. The risk is increased by other illnesses such as HIV or medications which compromise the immune system. Patterns of PTB infection. There are two major patterns of disease with TB. Primary tuberculosis, seen as an initial infection, usually in children. The initial focus of infection is a small subpleural granuloma accompanied by granulomatous hilar lymph node infection. Together, these make up the ghon complex. In nearly all cases, these granulomas resolve and there is no further spread of the infection. Secondary tuberculosis, seen mostly in adults as a reactivation of previous infection, or reinfection, particularly when health status declines. The granulomatous inflammation is much more florid and widespread. Typically, the upper lung lobes are most affected, and cavitation can occur. 2. Extrapulmonary TB. Extrapulmonary TB is TB that involves parts of the body outside of the lungs, such as the bones or organs. Symptoms depend on the part of the body affected. TB lymphadenitis. TB lymphadenitis is the most common type of extrapulmonary TB and involves the lymph nodes. It tends to affect the cervical lymph nodes, which are the lymph nodes in neck. But any lymph node can be affected. Swollen lymph nodes may be the only symptom you notice. But TB lymphadenitis can also cause fever, fatigue, unexplained weight loss, night sweats. Skeletal TB. Skeletal TB, or bone TB, is TB that spreads to bones from lungs or lymph nodes. It can affect any of bones, including spine and joints. While skeletal TB is rare, it's been on the rise in some countries with high rates of HIV transmission and AIDS, which both weaken immune system. Initially, skeletal TB doesn't cause symptoms. But over time, it can cause general active TB symptoms in addition to severe back pain, stiffness, swelling, abscesses, bone deformities. Miliary TB. Miliary TB is a form of TB that spreads in the body, affecting one or several organs. This type of TB often affects the lungs, bone marrow, and liver. But it can also spread to other parts of the body, including the spinal cord, brain, and heart. Military TB causes general active TB symptoms in addition to other symptoms, depending on the body parts involved. For example, if bone marrow is affected, patient may have a low red blood cell count or a rash. Genitourinary TB. Genitourinary TB is the second most common type of extrapulmonary TB. It can affect any part of the genitals or urinary tract, but the kidneys are the most common sites. It usually spreads to the area from the lungs through the blood or lymph nodes. Genitourinary TB can be spread through intercourse, though this is rare. People with this type of TB often develop a tuberculous ulcer on the penis or in the genital tract. Other symptoms of genitourinary TB depend on the parts affected and may include testicular swelling, painful urination, decreased or interrupted flow of urine, pelvic pain, back pain, decreased semen volume, infertility. Liver TB. Liver TB is also called hepatic TB. It occurs when TB affects the liver. It accounts for less than 1% of all TB infections. Liver TB can spread to the liver from the lungs, gastrointestinal tract, lymph nodes, or the portal vein. Symptoms of liver TB include high-grade fever, upper abdominal pain, liver enlargement, jaundice. Gastrointestinal TB. Gastrointestinal TB is a TB infection that involves any part of the gastrointestinal tract, which extends from the mouth to the anus. This type of TB causes symptoms similar to other gastrointestinal conditions, such as Crohn's disease. Symptoms of gastrointestinal TB depend on the area of the tract infected and may include abdominal pain, loss of appetite, weight loss, change in bowel habits, such as diarrhea or constipation, nausea, vomiting, an abdominal mass you can feel. TB meningitis. Also known as meningeal tuberculosis, TB meningitis spreads to the meninges, which are the membranes surrounding the brain and spinal cord. TB can spread to the meninges from the lungs or through the bloodstream. Unlike other types of meningitis that develop quickly, TB meningitis usually develops gradually. It often causes vague symptoms in the beginning, including aches and pains, fatigue, loss of appetite, persistent headache, low-grade fever, nausea and vomiting. As the condition progresses, it can also bring on severe headaches, sensitivity to light, neck stiffness. TB peritonitis. TB peritonitis is TB that causes inflammation of the peritoneum, which is a layer of tissue that covers the inside of your abdomen and most of its organs. It affects 3.5% of people with pulmonary TB and as many as 58% of people with abdominal TB. Ascites and fever are the most common symptoms of TB peritonitis. Ascites is a buildup of fluid in the abdomen that causes abdominal swelling, bloating, and tenderness. Other symptoms include nausea, vomiting, loss of appetite. TB pericarditis. TB pericarditis occurs when TB spreads to the pericardium. This consists of two thin layers of tissue separated by fluid that surround the heart and hold it in place. It can present as different types of pericarditis, including constrictive pericarditis, pericardial effusion, or effusive constrictive pericarditis. Symptoms of TB pericarditis include chest pain, fever, palpitations, shortness of breath, cough. Cutaneous TB. Cutaneous TB affects the skin. It's very rare, even in countries where TB is common. There are several different types of cutaneous TB, and it can spread to other parts of the body. The main symptoms of cutaneous TB are usually sores or lesions in different areas, particularly the elbows, hands, buttocks, area behind the knees, feet. These lesions may be flat and painless, purplish or brownish red, wart-like in appearance, small bumps, ulcers, abscesses. Risk factors. Causes of acquiring tuberculosis include the following: close contact. Having close contact with someone who has an active TB. Low immunity. Immunocompromised status like those with HIV, cancer, or transplanted organs increases the risk of acquiring tuberculosis. Substance abuse. People who are for-injection drug users and alcoholics have a greater chance of acquiring tuberculosis. Inadequate health care. Any person without adequate health care like the homeless, impoverished, and the minorities often develop active TB. Immigration. Immigration from countries with a high prevalence of TB could affect the patient. Overcrowding. Living in an overcrowded, substandard housing increases the spreading of the infection. Etiology. The main cause of TB is Mycobacterium tuberculosis, MTB, a small, aerobic, non-motile bacillus. The high lipid content of this pathogen accounts for many of its unique clinical characteristics. It divides every 16 to 20 hours, which is an extremely slow rate compared with other bacteria, which usually divide in less than an hour. Mycobacteria have an outer membrane lipid bilayer. If a gram stain is performed, MTB either stains very weakly, gram-positive, or does not retain dye as a result of the high lipid and mycolic acid content of its cell wall. Pathophysiology. Tuberculosis is a highly infectious, airborne disease. Pathophysiology and schematic diagram for pulmonary tuberculosis. Inhalation. Tuberculosis begins when a susceptible person inhales mycobacteria and becomes infected. Transmission. The bacteria are transmitted through the airways to the alveoli, and are also transported via a lymph system and bloodstream to other parts of the body. Defense. The body's immune system responds by initiating an inflammatory reaction, and phagocytes engulf many of the bacteria, and TB-specific lymphocytes lyse the bacilli and normal tissue. Protection. Granulomas, new tissue masses of live and dead bacilli, it surrounded by macrophages, which form a protective wall. Ghon's tubercle. They are then transformed to a fibrous tissue mass, the central portion of which is called a ghon tubercle. Scarring. The bacteria and macrophages turns into a cheesy mass that may become calcified and form a collagenous scar. Dormancy. At this point, the bacteria become dormant, and there is no further progression of active disease. Activation. After initial exposure and infection, active disease may develop because of a compromised or inadequate immune system response. Clinical manifestations. After an incubation period of 4 to 8 weeks, TB is usually asymptomatic in primary infection. Non-specific symptoms. Non-specific symptoms may be produced such as fatigue, weakness, anorexia, weight loss, night sweats, and low-grade fever as the typical hallmarks of tuberculosis. Cough. The patient may experience cough with mucopurulent sputum. Hemoptysis. Occasional hemoptysis or blood on the saliva is common in TB patients. Chest pains. The patient may also complain of chest pain as a part of discomfort. Assessment and diagnostic findings. To diagnose tuberculosis, the following tests could be performed. Complete history. Past and present medical history is assessed as well. Physical examination. A TB patient loses weight dramatically and may show the loss in physical appearance. Sputum culture, positive for Mycobacterium tuberculosis in the active stage of the disease. Gihel-Nielsen, acid-fast stain applied to a smear of body fluid positive for acid-fast bacilli, AFB. Skin tests, purified protein derivative, PPD, or old tuberculin, OT, administered by intradermal injection, mantoux, a positive reaction, area of induration 10 mm or greater, occurring 48-72 hr after intradermal injection of the antigen, indicates past infection and the presence of antibodies but is not necessarily indicative of active disease. Enzyme-linked immunosorbent assay, ELISA, Western blot, may reveal presence of HIV. Chest X-ray, may show small, patchy infiltrations of early lesions in the upper lung field, calcium deposits of healed primary lesions, or fluid of an effusion. Changes indicating more advanced TB may include cavitation, scar tissue fibrotic areas. CT or MRI scan determines degree of lung damage and may confirm a difficult diagnosis. Bronchoscopy shows inflammation and altered lung tissue. May also be performed to obtain sputum if patient is unable to produce an adequate specimen. Histologic or tissue cultures, including gastric washings, urine and cerebrospinal fluid, CSF, skin biopsy positive for Mycobacterium tuberculosis and may indicate extrapulmonary involvement. Needle biopsy of lung tissue, positive for granulomas of TB, presence of giant cells indicating necrosis. Electrolytes may be abnormal depending on the location and severity of infection, e.g., hyponatremia caused by abnormal water retention may be found in extensive chronic pulmonary TB. ABGs may be abnormal depending on location, severity, and residual damage to the lungs. Pulmonary function studies, decreased vital capacity, increased dead space, increased ratio of residual air to total lung capacity, and decreased oxygen saturation are secondary to parenchymal infiltration fibrosis, loss of lung tissue, and pleural disease, extensive chronic pulmonary TB. Medical management. Pulmonary tuberculosis is treated primarily with anti-tuberculosis agents for 6 to 12 months. Active TB. For most adults with active TB, the recommended dosing includes the administration of all 4 drugs daily for 2 months, followed by 4 months of INH and RIF. Latent TB. Latent TB is usually treated daily for 9 months. Treatment guidelines. Recommended treatment guidelines for newly diagnosed cases of pulmonary TB have 2 parts, an initial treatment phase and a continuation phase. Initial phase. The initial phase consists of a multiple medication regimen of INH, rifampin, pyrazinamide, and ethambutol and lasts for 8 weeks. Continuation phase. The continuation phase of treatment include INH and rifampin or INH and rifapentine, and lasts for an additional 4 or 7 months. Prophylactic isoniazid. Prophylactic INH treatment involves taking daily doses for 6 to 12 months. Directly observed therapy may be selected, wherein an assigned caregiver directly observes the administration of the drug. First-line treatment. First-line agents for the treatment of tuberculosis are isoniazid, INH, rifampin, RIF, ethambutol, EMB, and pyrazinamide. Isoniazid, INH. INH is a bactericidal agent that is used as prophylaxis for neuritis, and has side effects of peripheral neuritis, hepatic enzyme elevation, hepatitis, and hypersensitivity. Rifampin, rifadin. Rifampin is a bactericidal agent that turns the urine and other body secretions into orange or red, and has common side effects of hepatitis, febrile reaction, purpura, nausea, and vomiting. Pyrazinamide. Pyrazinamide is a bactericidal agent which increases the uric acid in the blood and has common side effects of hyperuricemia, hepatotoxicity, skin rash, arthralgias, and GI distress. Ethambutol, myambutol. Ethambutol is a bacteriostatic agent that should be used with caution with renal disease, and has common side effects of optic neuritis and skin rash. Nursing management. Nursing management includes the following. Nursing assessment. The nurse may assess the following. Complete history. Past and present medical history is assessed as well as both of the parents' histories. Physical examination. A TB patient loses weight dramatically and may show the loss in physical appearance. Nursing diagnosis. Based on the assessment data, the major nursing diagnoses for the patient include risk for infection related to inadequate primary defenses and lowered resistance, ineffective airway clearance related to thick, viscous, or bloody secretions, risk for impaired gas exchange related to decrease in effective lung surface, activity intolerance related to imbalance between oxygen supply and demand, imbalanced nutrition less than body requirements related to inability to ingest adequate nutrients. Nursing care planning and goals. The major goals for the patient include promote airway clearance, adhere to treatment regimen, promote activity and adequate nutrition, prevent spread of tuberculosis infection. Nursing interventions. Nursing interventions for the patient include promoting airway clearance. The nurse instructs the patient about correct positioning to facilitate drainage and to increase fluid intake to promote systemic hydration. Adherence to the treatment regimen. The nurse should teach the patient that TB is a communicable disease and taking medications is the most effective means of preventing transmission. Promoting activity and adequate nutrition. The nurse plans a progressive activity schedule that focuses on increasing activity tolerance and muscle strength and a nutritional plan that allows for small, frequent meals. Preventing spreading of tuberculosis infection. The nurse carefully instructs the patient about important hygienic measures including mouth care, covering the mouth and nose when coughing and sneezing, proper disposal of tissues, and hand washing. Acid-fast bacillus isolation. Initiate AFB isolation immediately, including the use of a private room with negative pressure in relation to surrounding areas and a minimum of 6 air changes per hour. Disposal. Place a covered trash can nearby or tape a lined bag to the side of the bed to dispose of used tissues. Monitor adverse effects. Be alert for adverse effects of medications. Evaluation. Expected patient outcomes include promoted airway clearance, adhered to treatment regimen, promoted activity and adequate nutrition, prevented spread of tuberculosis infection, discharge and home care guidelines. Before the discharge, the nurse should instruct the patient to disposal of secretions, cough and sneeze into tissues and to dispose of all secretions in a separate trash can. Isolation. Wear a mask when going outside of the room. Activity and nutrition. Remind the patient to take a lot of rest and to eat balanced meals to aid recovery. Adverse effects. Advise the patient to watch out for adverse effects of medications and to report them to the physician immediately. Prevention. To prevent transmission of tuberculosis, the following should be implemented. Identification and treatment. Early identification and treatment of persons with active TB. Prevention. Prevention of spread of infectious droplet nuclei by source control methods and by reduction of microbial contamination of indoor air. Surveillance. Maintain surveillance for TB infection among healthcare workers by routine, periodic tuberculin skin testing. Complications. If left untreated or mistreated, pulmonary tuberculosis may lead to respiratory failure. Respiratory failure is one of the most common complications of pulmonary tuberculosis. Pneumothorax. Pneumothorax becomes a complication when tuberculosis is not treated properly. Pneumonia. One of the most fatal complications of tuberculosis is pneumonia, as it could cause infection all over the lungs.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.